Okay, ladies and gentlemen, you're about to receive the world's first international medical podcast, hosted by 3 paramedics from different countries. Live from the UK, Finland and Australia, this is
Hi guys, and thank you for tuning in. Today we're going to bust 10 most or biggest medical lies, most common medical myths, but that's not all. We're also going to give you an amazing clinical tool to protect you, or to let you protect yourself from so-called garbage science, or just, let's say it, medical bullshit. Can I say bullshit on this show?
For
mate, what revenue are you talking about? We have like 3 viewers, like my mom, your mom, and Temu's mom. So, hello, what money you are worrying about? Anyway, ladies and gents, if you're still intubating using 23-21 technique, if you're still giving charcoal not later than 1 hour, if you still believe in hypoxic drive, you need to stay tuned with us. This is Group Call Live. So let's start with myth number 10, and this is fentanyl will kill you if you will touch it. Everything started with the body cam video that went absolutely viral in America. But before we will talk about the fentanyl itself, let's just see the video.
On July 3rd, while on a call, Deputy David Five-Eye from the San Marcos station found a white substance that he suspected was drugs in this red Jeep. It tested positive for fentanyl on the scene. Unfortunately, he was already quickly exposed to it.
I was like, hey dude, too close. You can't get that close to it. A couple seconds later, he took some steps back and he collapsed.
Five-Eye's field training officer, Corporal Scott Crane, spoke in the video released by the department detailing his instant reaction. He realized Five-Eye was overdosing and quickly gave him naloxone, also known as Narcan, which reverses the effects of an overdose.
My lungs just locked up. I couldn't breathe.
Came down to him, grabbed him, and I did 1 nasal spray in 1 nostril, opened the other one, another nasal spray.
Crane stayed by his side as medics arrived. Five-Eye OD'd again while in the ambulance on the way to the hospital, but thankfully he survived. The Sheriff's Department now using the intense footage to warn the public of the dangers of fentanyl.
So, this is the case that, the myth that originated in America. So, let's see what Gina, our American correspondent, wants to say.
Hello, my name is Gina LaRue-Wendy. I'm from the United States of America, and today we're going over medical myths. So the medical myth I'm first talking about is fentanyl. If I touch fentanyl, can I die? So let's start what fentanyl is. Specifically, other than a pain medication. Fentanyl is a synthetic opioid that is 80 to 100 times stronger than morphine. Initially, it's used for cancer patients in the 1960s. They developed that. But because of that opioid kind of narcotic property, it makes people like addicted to it. It has highly addictive properties. So there's street names here in St. Louis, and then street names in all over the world, and I only know a couple. So China, China Girl, Chinatown, Dance Fever, Goodfellows, Great Bear, He-Man, King, King Ivory, Murder 8, Tango and Cash, and so many more. So if you guys know any, please place it on the comments. Usually the synthetic can be lab made, like in an actual like physical medication lab, or at home, and they make fentanyl like in street labs. In street labs, the most of the stuff is considered powder, or they put it into a pill form, and this pill form is masked. It can look like oxycodone, it can look like a Percocet, it can look like a different pill entirely, but it's actually fentanyl. Fentanyl can be smoked, snorted, sniffed, taken orally by pill or tablet, spiked onto a blotter, tissue paper. Fentanyl patches. Fentanyl has prescription patches, and then they can make their own type of patches. what they normally do for the prescription patches is they take the gel from it, lift up the gel, scrape it off, liquefy it, and then inject it. It seems like a lot of work for 100 micrograms of fentanyl. Just saying. So with that being said, let's get into like, what is it specifically? It's a Schedule II narcotic. According to the U.S. Controlled Substance Act, it's Schedule II. A lot of officers, whenever they had that initial reaction to touching fentanyl, they were many different areas where they would collapse. Well, let's talk about like the absorption rate into the actual skin and go from there. So fentanyl is an amenable to transdermal absorption because it's low molecular weight. The lipid phosphophility, depending upon the specific product. Transdermal delivery system patches usually take 3 to 13 hours to produce a therapeutic effect. And most of the fentanyl patches come in about 100 micrograms of fentanyl, which, remember how I specifically said during the beginning, it was 1 dose. That's the one maximum dose that we can give. These patches use moisture, so there's a specific goo that is mixed in and that it produces moisture and heat, and that goo locks it in to that skin so it can be absorbed that way. However, accidental dermal absorption is unlikely to cause this opioid toxicity. And that's the reason why, is because it needs that moisture and heat and something to lock it into place. Otherwise, that powder or substance or tablets is just going to sit on the skin because the molecular weight, it can't get into the skin. So fentanyl can be brushed off first and then wash it with soap and water. Copious amounts of soap and water if you feel better. Do not use hand sanitizer because what it does is it opens up the skin, and that could be an absorption right into the skin. As far as mucous membranes go, talking about the nose, ears, throat, again, slower molecular. If you were exposed, you would have signs and symptoms, maybe a long time, but you would actually have time to decontaminate yourself. Understanding slower absorption rates to fentanyl powder or pill, then it's unlikely to cause an unintentional skin exposure that can cause a significant overdose. Again, an overdose, it would be constricted pupils, low respiratory rates, hard to arouse, maybe lethargic, things like that. In a lot of these officers, you see them are firefighters or anybody who could have an exposure, the heart rate could jump up. They look like they're having a panic attack. I did some research, and a lot of times it's called the nocebo effect, which is kind of like placebo, but the negative effect of it. It's just the thought of the exposure, being exposed to itself, can cause kind of like a bad anxiety attack. So with that being said, the slower absorption rate and this nocebo effect, it's very unlikely uncommon. I did see that officer video as well. Unfortunately, I did not see him wear any personal protective equipment like gloves. There's not very much like a clear video of what specifically happened, if he even touched that actual specific substance. So unfortunately, I don't know if maybe he touched the substance with his bare hands. Again, slower absorption rate. Maybe he touched his eyes and his face, but just to pass out like that, due to our research and what we were talking about, it's a very slow, slim chance that that could happen, but that nocebo effect is very possible.
Jens, any thoughts?
Yeah, I saw the video for the first time now. I found it quite interesting that the officer that had the reaction also closed his eyes when the nasal naloxone was introduced. So he was clearly not that out of it. Yeah, I think this is like some Fox News stuff.
Yeah, I remember when it first came out and did the rounds on social media, and I think all the non-medical community were going, "Oh, look at this horrible, dangerous thing." I think anyone that sort of knew half of what they were talking about, which is like, this is crap. This is not what happens. I mean, like, it took them how many decades to design fentanyl patches because, as Gina mentioned, it absorbs so poorly through the skin. It's not, you're not going to touch it and instantly go into respiratory depression.
Now imagine
it's not what happens.
Now imagine all those critical care nurses or ICU nurses or theater nurses who just pop the fentanyl ampule and then bosh. That would be absolutely crazy.
Exactly.
Ladies and gents, and I'm now talking to my amazing viewers. All research papers that we are using in this episode will be linked down below in the description to the video. So if you would like to read more about things that we discuss or we will discuss today, please do not hesitate. Pop the link down below and just see. All right, time is not our friend today, so let's go quickly to myth number 9. And the myth number 9 is you need to administer activated charcoal within 1 hour from the moment when your patient will eat something. And this myth originated from a very old study describing the speed of the gastric emptying. Now, basically, we believed that everything that we eat is flushed down from our stomach within 1 hour. Now, let me use the B word again, because let me remind you, Timu dropped a few F-bombs recently, so...
So he's set a precedent, hasn't he?
Absolutely. So I will use the B word. Sorry, guys, it is bullshit. Now, there are 3 very important papers that actually busting this myth, and I just want to make a big shout out to Dr. Josh Tribach from Twitter. Hello, Dr. Tribach, United States of America. He actually made this point, and I'm just quoting his research. So 3 papers. The first one is mmHg and et al. So basically, they did endoscopies on the patients who overdose on drugs, and over 60% of patients had contents still in the stomach more than or longer than 1 hour after ingestion. That's paper number 1. The paper number 2, it will be Adams and colleagues. So they took patients who overdosed and measured the gastric emptying time. Now, what they've done was they measured the gastric emptying later also when they were not overdosed, and they compared the time. So they found that overdose caused gastric hypomobility, so slower absorption, slower work, and delaying emptying. And the last paper, Lifshitz et al. So the authors examined patients who died from drug overdose, sadly, and found that more than 10% patients still had retained drugs in their GI tract. So the myth about 1 hour is busted. Happy? Any thoughts?
Yeah, I think like that's a case where just you jump to conclusions based on one study, which is clearly not how we should do things at all.
And also sometimes we use so old research.
Yeah.
Yeah, can someone say adrenaline and cardiac arrest?
Ooh.
Basing off old research.
Yeah.
I think that's a topic for another time, I think.
Oh, yeah, absolutely. So let's quickly jump. Let's change the subject. Myth number 8. You should administer ice rectally for overdose. And again, ladies and gents, this is so American thing. So, guys, a quick one. Why this question? Why this myth? How can we come across this myth? So we asked the question to the Reddit users about 10 biggest medical lies or biggest shit, and that's what they came up with. User Cosmonaut said about this drug overdose. He said, ice for overdoses. I used to see that all the time. Hookers in the bathtub covered in ice. Definitely thought it was some organ harvesting shit the first time I saw it. Mirrors Brightly said, we heard a run of bystanders administering rectal ice for heroin overdose. Amazingly, it did nothing. User Cam 27022, he said, or she said, that's right, I remember it was something to do with an AMS condition. And Mac Attack 94 said, ice in the poop hole for heroin overdose. So again, that's so American thing. I asked Gina, tell us something about this crazy thing.
As far as like fentanyl and overdoses in general with ice, ice is just, people believe that if I throw ice on you, it's going to wake you up. Kind of like if you throw water on somebody, it's going to wake them up. And what it actually does is just makes them colder. It doesn't do really specifically anything. A lot of St. Louis people, a lot of people that go to have narcotics, they are prepared with Narcan. And Narcan is an opioid antagonist so that it can relieve that fentanyl or that opioid on that receptor site so that they can start breathing on their own effectively. But not ice. Ice is just going to make them cold. Sticking in a junk, specifically the female's breast, genitalia, same thing with dudes, genitalia, specifically in the rectum, it's supposed to cause pain so that they can wake up. Well, if I have a pain pill, like, you know, it's a narcotic, it's an opioid, they're not going to wake up to that specific pain because they're taking pain medicine. But anyway, so it does nothing. That's just a myth. It just makes them cold. And then when they wake up, they're like, why am I wet? Why is there a ranch on me? Why am I covered in milk? I can't make this stuff up. So with that being said, please have a great day.
Oh, absolutely, we will. I just no. Pouring milk over overdosing patients, putting or putting ice in the rectum.
This reminds me of like an old Finnish saying that you can get used to anything except an icicle up your bum.
I must be way too innocent because I'd never heard of this before we discussed this topic for this podcast, putting ice in someone's rectal cavity as a treatment for OD. It's just baffling how someone would come up with that. It's like, what, decrease the core temperature and like decrease the metabolic? I don't know the rationale for it. I think Gina's on the money in terms of just giving someone an excuse to play with someone who's unconscious.
Absolutely. Good. So let's move on to myth number 6. And the myth is, if they a seizure, please hold their tongue.
Yeah, so this is one that's kind of interesting. There's a couple of medical providers who still believe this, but broadly speaking, just in the general public, a lot of people seem to still think this, that you need to hold someone's tongue while they're actively seizing, otherwise they will choke on their tongue and they'll die. This seems, again, should seem reasonably obvious to anyone that sort of knows anything about physiology, that the patient's going to be more likely to probably bite your finger off and then choke on your finger than they are to choke on their own tongue, because choking on your own tongue is physiologically impossible. So if you try put your tongue down the back of your throat, you'll notice that there's a little frenulum that sort of attaches your tongue to the base of your mouth, the floor of your mouth. So you couldn't swallow your actual tongue even if you really, really wanted to. I mean, it is possible that if someone's lying supine and they lose their airway reflexes, that their tongue can obstruct their airway when those structures shift backwards, similar to how it does in like sleep apnea. But that's just one of the many reasons why I want to put these patients in a lateral position, recovery position, it'll often be called. It also will help if they do vomit, that prevent them from aspirating. Now, likewise, trying to hold a patient's tongue to avoid them biting it is not really going to be of any use, because they're going to bite their tongue anyway. And if you're holding it with your fingers, they're going to bite your fingers. Moral of the story, don't put anything inside a patient's mouth while they're actively seizing. This should be reasonably obvious. No fingers, no wallets, no OPAs. They're probably going to be having trismus anyway, so an OPA is going to be very difficult to put in, especially while they're actively seizing. If a patient has an airway that's not patent while they're actively seasoning, and you've repositioned and you've done all your BLS care, excuse me, then look, considering an NPA might be appropriate. Terminating the seizure pharmacologically, midazolam, diazepam, whatever your agent of use in your service, and then managing the airway as appropriate. That's probably fine, but as routine care, don't grab a patient's tongue while they're seizing. It's stupid and just makes no sense and is too dangerous. But we did have a Reddit comment come from a Wayfan 2022. He said, I know a couple of hospitalists who believe that spraying saline in the face of someone in the middle of having an epileptic seizure will break the patient seizing, and they'd rather do that than give Ativan or Versed. This is, once again, just baffling to me. I've never heard of this practice. I don't know if it's uniquely American, uniquely in this particular hospital. I tried to do some research on it, and I couldn't find anything. The only topics that were even vaguely linked were talking about psychogenic non-epileptic seizures, and you can go back to, I think it was episode 3 for us for a bit of a discussion on those. Correct. So look, that might be a possibility with the management of them, but again, I don't advocate for this. Spraying someone in the face with saline. I'll spray my work partner in the face if I'm trying to be a dick, but I'm not going to do it to any patient. Once again, we always say rely on your service's guidelines. If your guideline says to spray someone in the face with saline, then do it. But otherwise, I don't think it's a very good idea.
Don't do it. I will.
Have you guys ever heard of that?
No. In both countries I worked, no. However, I will top up your holding the patient's tongue with the fingers with a safety pin, because in very old textbooks in Poland, we supposed to use the safety pin to pin the tongue to the patient's cheek or lips.
I think I've seen similar diagrams of that in first aid textbooks of years gone by. Don't stab a pin through someone's tongue, just in general.
Definitely not.
It's just not nice.
And now, as we are in this world of neurosystem, let's see the next myth is after a concussion, you cannot or should not let the patient to fall asleep.
Yeah, so this seems to be a longer standing one. And I mean, at least here in Australia, the management of concussions is sort of undergoing a bit of review and improvement over the last several years, and particularly based from like junior and amateur and professional sport as well. There's been a lot of learnings from that. So look, briefly on what a concussion is, it's typically very minor and usually short-lived brain injury, and it occurs due to trauma. And something I learned as well, it comes from the Latin word concutare. My Latin is not great, meaning to shake violently, and that's what happens basically in any sort of trauma to the head or to the brain. And that shaking violently, you can get what's called a coup injury, where the brain impacts the side of the head that's been impacted. You can get a contra coup injury because of the inertia, so that acceleration, deceleration, your brain's just shaking around in your cranial vault basically, and it can lead to like a really broad degree of symptoms, so headaches, nausea, confusion. Usually it happens straight after, but it can develop hours, days post the incident. So there's been this long-standing sort of idea that you shouldn't let someone that's suffered a concussion, you shouldn't let them go to sleep. And the rationale for this kind of makes sense on face value, but it's more just for our own benefit. So the rationale being that if a patient's asleep, they're more difficult to monitor. So again, it's coming back to making our lives easier. Once again, plugging in another one of our episodes talking about management of maternal patients where they're lying on their back with their legs up. It makes our job easier. It doesn't make the patient's job easier. But this thinking has been sort of misinterpreted to the sleeping itself causes coma, causes death, which is just absolutely ridiculous. You know, going to sleep doesn't cause you to die. But anyway, so there's absolutely no evidence that the actual sleeping worsens concussions in any way, shape, or form. And it's actually a really, really important part of the recovery process. So it's often recommended now that for the days and weeks following a concussion, that patients really aim to decrease their cognitive load, their cognitive activity. So same as when you get a soft tissue injury, pull a hamstring or something, you don't want to be running any marathons or anything. Same happens with concussion. If you get a head knock, you want to be avoiding any mentally strenuous activity to allow your brain to recover. They're still often recommended by some services to wake a patient up every 2 hours. And again, that's more just so we can reassess them. But generally speaking, it's not really required for monitoring a patient. If there's a really, really strong suspicion they might deteriorate, then yeah, making sure they're easily rousable, but you don't have to wake them up and get them to walk around the block or anything. In most circumstances, you can just monitor vital signs, make sure there's no change to their respiratory drive. Most of these symptoms will resolve with rest over, again, the days to weeks afterwards. Paracetamol or acetaminophen, I think it's called over in the US, were appropriate for headaches, antiemetics if required, and then obviously treating any more serious head injuries as appropriate. One important thing to keep an eye on as well, and this is an area that's not really researched well at the moment, is what's called secondary impact syndrome. So it's not very well known about, very studied, because it's quite rare, but it's a potentially fatal complication of concussions. So if someone's still recovering from a concussion, they're still symptomatic, their brain's still resting and repairing, and if they suffer another trauma to the head, it can be relatively minor. It can result in a really rapid decompensation, a rapid swelling of their brain, and often death is reported within minutes. So patients shouldn't return to any sort of contact physical activity until all their symptoms are gone and they've been cleared by a doctor. And at least over here in Australia, it'd be interesting to hear how it is in other countries as well. A lot of our junior sport codes, a lot of the professional codes as well, have rules around patients or players that have suffered a concussion being mandated as sidelined for a period of time and then having to have medical review before they return. So that's definitely the case in a lot of professional codes, and increasingly the case with a lot of junior sport as well, which is really, really important. So, but as to whether they can go to bed if they're tired, absolutely. It has no bearing on it probably improves their recovery if anything.
I just found the poem by Percy Shelley, Tonight, and it's about death basically, but this poet refers to death as a brother of sleep. Maybe that's something that play a role in this bloody myth, but
yeah, mate.
Yeah,
maybe it's come from that poem. Yeah.
Anyway, there's nothing like this in the UK. I mean, okay, so in the, let's say, common knowledge. So if you would ask bystanders, civilians, yes, definitely they say, oh, you should not let them fall asleep. But in terms of guidelines, there's nothing about waking them up and so on. What about far north, Mr. Silver?
Yeah, I think yeah, I don't know actually.
You are still sleepy.
It's a new one, really. Yeah, yeah. Sorry. Yeah.
No, that's absolutely fine. Good. Is it time for the next myth? And this is myth number 5. The blood is actually blue, not red. And this came again from our amazing viewers from Reddit. CJ said, I argued with a registered nurse who said that all blood is blue in the body and only turns red when it mixes with the gases in the outside atmosphere. And user Moracle74 said, yes, this myth is still taught in schools. It's just like people forget the oxygen is in the body too. And I cannot argue more. I mean, there are so many researchers, there are so many papers to prove that the blood is red. And we actually put this myth so high up because it's still taught in schools. So no, okay, on the diagrams you can see blood, the venous blood being blue and the red blood being, arterious blood being red. But it's only to distinguish those two flows. It's not about blood being blue, okay? And yes, we have oxygen in the body too, so absolutely not.
And I don't understand the justification with it only turns red when it mixes with gases in the atmosphere. I mean, what happens when you draw a vial of venous blood? There's no air in that syringe, in that vial, and that's still red. So
crazy.
There we are.
Crazy. Absolutely.
It should be obvious. I shouldn't even need to say that, but
hello. Good. Myth number 4. And this is the radial pulse is present when the systolic pressure is 80 millimeters of mercury or more. And this myth everything started in 1985 when Advanced Trauma Life Support textbook was published. And basically what happened is that ATLS strongly correlated radial pulse and the blood pressure. And basically they said that if your patient has a radial pulse, palpable, the blood pressure, the systolic will be at least 80 millimeters of mercury. And this myth was slightly corrected by Dr. Charles Dakin, who is now Professor Charles Dakin, who on sample of 20 patients proven that basically radial pulse can be palpable in patients with the systolic of 70. Now, the big thing, the biggest research was published a year ago by American military doctors who on sample of 28,000 patients proven that radial pulse can be palpable in the blood pressure lower than 80. More than that, in patients with systolic blood pressure lower than 80, a radial pulse was described by clinicians as strong. So again, please don't think that if you check the pulse, if they have radial pulse, their systolic is 80 millimeters of mercury. This is not true, and we have a big research over 28,000 patients. Is that the same thing, guys? Are you familiar with this in Finland and Australia?
Yeah, I think it's still a thing that gets taught, but it's usually like prefaced with like this is not entirely true. So like they kind of like generalize it. So if you feel the radial pulse, blood pressure should be around 80 or over, but it might not be, sort of like that. And same for the carotid as well, and 60 millimeters of mercury for that one. So it gets taught, but there is like a caution sign next to it, which is good.
Yeah, same over here. I wouldn't say it's not part of the curriculum, but people sort of tell you along the way. It's like, yeah, look, hey, this is maybe a bit of a guide, but it's definitely not spoken about as gospel or anything.
Cool. Guys, I'm very sorry to our viewers and listeners. We lost connection for a second, but that's, I think, due to the massive storm now over the UK that affected...
It's because you said bullshit too many times. YouTube just pulled the plug on us.
Yeah, or it's your mom, my mom, or Temu's mom who just said, no, naughty boys.
No.
Yeah, so sorry, I know that we are back now, so please join us on Facebook Live, on YouTube, and on Twitter. We're also live on Twitter now. Cool. Now, myth number 3, which is you need to intubate using 21-23 centimeter rule. And now, this myth originated from one only American study that was published in 1995, and the sample was 83 patients. Okay, they were all Caucasian, and all males were taller than females. Now, we were using this rule for ages, and now we have a bit more diverse community. We have a bit more diverse population than just Caucasian and men taller than female. So if you will ask what to use, there's an amazing thing called Chula formula, and as with all the research we mentioned today, I will pop the link down below. And the Chula formula is patient's height times 0.1 plus 4. It's very simple. You basically take away 100 from the patient's height. And again, it's only for adults. So let's say myself, I am 190 centimeters in height. So if you will times it by 0.1, it gives you 19, and then plus 4, it gives you 23. So for me, actually, this formula would be cool. But if someone is, let's say, 170 centimeters in height, times 0.1 is 17, and then plus 4 is 21, and so on, so on, so on. And taller people like 2 meters, it's 20, plus 4 is 24, and so on, so on, so on. So again, please remember the Chula formula, not 2321, and the research for Chula formula will be in the link below in the description to this video. I know that Australians, you guys don't intubate if you're not critical paramedics, right?
Yeah, with pretty much all the services in the country, that's the case. It's only intensive care paramedics that'll intubate. So yeah. Okay.
Teemu, you are intubator, aren't you?
Yes, but it is very, very rare that we do. And then basically, like, I think 99% of the time it will still be the doctor that will do it. So I don't need to actually, I will just be assisting. If I was doing it on my own, then it would just be like an approximation. I wouldn't use the 21-23 rule, but I didn't know about the Chula formula either. So
okay, so
TIL.
Again, remember, it is patient's height times 0.1 plus 4. Chula formula, I really recommend it. It's really good. Now I think it's time for myth number 2, and I'm good on counting down. It is myth number 2, which is you need to raise the patient's legs to improve their blood pressure.
Yeah, so this one comes from, I think, from a German surgeon called Friedrich Trendelenburg. Coincidentally, the name is also what was used to name the Trendelenburg position. He created it in the start of the 19th century to improve surgical exposure of the pelvic organs during surgery. And then during World War I, Walter Cannon, a famous American doctor, he popularized the use of Trendelenburg position as a treatment for shock. And it was promoted as a way to increase the venous return to the heart, increase cardiac output, improve organ perfusion. And then a decade later, actually, Mr. Cannon also reversed his opinion on the benefits of the Trendelenburg position, but that did not deter the widespread use. So today, the Trendelenburg position is still like a really widely used tradition as an early management of hypotensive patient. I'm talking about Trendelenburg position, but we could also be talking about leg raise. The only difference is that you obviously dip the head down, and you get slightly more negatives from the Trendelenburg than from the leg raise, but it's still pretty much the same. The problem is that there's really flimsy evidence base surrounding this. So when we say it's a myth, we actually don't know, but it's being thought as fact. So that's the problem. In 2007, there was a summary of 5 research studies, and the review of them did not provide any overwhelming support for its use as a treatment for hypotension. It did improve cardiac parameters, but only for a little while. And it was always, well, most of the time, it was followed by hemodynamic deterioration. And there were also like other adverse effects, especially in like people who were obese, had compromised right ventricular ejection fraction, a pulmonary disorder, or a head injury, especially in Trendelenburg, not so much in the leg raise. So as it stands at the moment, it really should be avoided as treatment for acute hypotension or shock until there's more like definitive and larger sample sizes and studies done on it. It can be still used as a position for insertion or removal of central venous catheters, which we don't really do in the ambulance, and also in certain like spinal anesthetic techniques, which we also don't do. but you shouldn't be using it as a treatment for hypotension. There is some studies at the moment that are like saying it can be used as an indicator for like fluid responsive shock. So if you raise the legs and you do get a blood pressure rise from it, that might be indicative that the shock or the hypotension will actually respond quite well to crystalloid fluids. Whereas if you raise the legs and nothing happens, then it's most likely not you won't be able to reverse the hypotension with just clear fluids.
Yeah, I found that one really, really interesting. To be honest, that's something that is taught over here. Is you always lift their legs up. If the blood pressure goes up, yeah, you're fine. Don't worry about it. But I mean, as you said, it's it's based on very flimsy evidence, and it's not so much that there's evidence yet to go against it, but there's just none to really support it. It was also very interesting that what was the American surgeon's name who said, yeah, this is great, and then a decade later he said, oh, actually I changed my mind, kind of thing. And yet we still go off the same thing. It kind of reminds me of another medical myth, very topical at the moment, the whole vaccines cause autism.
Yeah, of course.
Exactly.
He put out this paper and everyone listens to that and then it gets retracted, but the damage is already done. That thinking's still in the mindset of a lot of people.
The big problem right now is that like the leg raise for blood pressure is really widely thought to like everybody as part of first aid, and then like even if we stop using it, it will still be used for like decades and decades before people actually everybody learns that it's not a good thing.
And it's gravity. It seems logical, doesn't it? So. Yeah,
absolutely.
It'll be interesting to see how the evidence goes over the next couple of years with it.
Cool. Now it brings us to the myth number one. And the myth number one, the biggest medical bullshit ever, is hypoxic drive.
Yeah, so this one is this might get a bit controversial as well. So the myth basically goes that with a patient with a acute exacerbation of COPD, chronic obstructive pulmonary disease, giving them oxygen will basically stop their drive to breathe. And it comes from the thought that because we have central and peripheral chemoreceptors, the central ones are responsible for detecting carbon dioxide levels in the body, and then the peripheral are responsible for detecting oxygen levels. The central ones are the primary culprits behind the drive to breathe, and then the oxygen ones, the peripheral ones, much less so. It's still being thought that increasing arterial O2 tension will actually reduce the respiratory drive, based on the fact that people think that COPD patients have been used to lower concentration of O2 in their blood. So if you increase it, their body will go, oh, I have enough oxygen, so I don't need to breathe anymore. And then it will actually lead to hypocapnia, and even dangerous level of hypocapnia. And this has actually led to clinicians and nurses to not administer oxygen to hypoxemic patients with COPD. In most cases, this is really unwise, and it's putting the safety of the patient as the risk. So the diagram that Alex is showing is basically showing us VQ mismatch, so ventilation perfusion mismatching. So what happens normally is that our body regulates, if we increase the ventilation, it will decrease the perfusion of the alveoli, or if we increase the perfusion of the alveoli, it will just match it. But what happens is if you increase the oxygen inside the blood, it will decrease the ventilation and it can actually lead to shunting, where the pressure in the alveoli and in the respiratory system will block any gases transferring from the blood. Also, like if you increase the inspiration, like the fraction of oxygen, it will increase the O2 tension in the alveoli. And with a low level of ventilation, it will be inhibiting hypoxic pulmonary vasoconstriction, which is responsible for reducing the perfusion of the alveoli. And as a result, the alveoli with relatively impaired ventilations are well perfused, and that will increase the VA-Q mismatch. And this was found to be about 75% of the hypercapnia in COPD patients. The other, like the 25%, comes from the Haldane effect. So our hemoglobin can bind to O2 or CO2. And if we increase the amount of O2 that the hemoglobin is binding to, it won't be able to bind to CO2 as much. And that will increase the partial pressure of CO2 in the blood, and that will shift the CO2 dissociation curve rightwards. And then normally that would lead to elevated minute ventilation, but with COPD patients, they can't really regulate their breathing like that. So then it will actually be just increasing the partial pressure of CO2 and lead to hypercapnia, and obviously acidosis and problems like that come from it. So what should we do instead of like holding back oxygen? So the patients that are most susceptible to oxygen-induced hypercapnia are those that have the most severe hypoxemia. And then we should be, for COPD patients, be titrating oxygen. And this is quite well thought, I think. It just somehow still like remains, like the myth remains on the side of this. So we should be aiming between 88 to 92% of O2, sometimes even higher, especially if we can monitor the CO2 levels, either through like the nasal cannula monitoring, or obviously if they are intubated, then through the inline capnometer, or if we can actually do arterial blood gas analysis, we can check it that way. So then we can actually give them more O2. And also we should be trying to increase the ventilation as well. So just giving O2 is bad. It's better to like use CPAP or stuff like that. So this is also like in accordance with the British Thoracic Society guidelines for oxygen therapy in patients with COPD. So yeah, give oxygen, aim for 88 to 92, sometimes higher, and definitely don't hold back just because they might stop breathing if you give them too much. That's not what happens at all.
Yeah, so much science.
I tried to keep it like surface level, so I didn't go too deep into VQ mismatch or Haldane, but it has a lot of science behind it. But the science was always there. It was, again, only a couple of studies with quite low N numbers that perpetrated the myth, and then it just spread, and now it's really widespread and still being taught.
But
yeah, I remember in my undergrad degree, at the first part of our semester, they said, yeah, hypoxic drive, this is this, this is that. And then it was about halfway through the semester, about week 7, our lecturer came back and said, okay, everything I told you about hypoxic drive, forget about it. Here's the new lecture. Forget all that. This is what it actually is. So, yeah. So it's all right, yeah. Alex, if you still believe the old school
because
way.
I'm old.
Nobody's perfect.
Yeah, and we will link the all the sources and the studies on this, and they will actually be better at describing the science behind it than I was able to.
But yeah, Teemu, thank you so much. Now I will take this part of the podcast and I will actually play it to my students, saying, "Here you go. That's the truth, not the bullshit we taught you before about hypoxic drive." But ladies and gentlemen, you just received 10 biggest medical lies in a pre-hospital emergency medicine. However, this is a group call life, so you will always get a bit more than you ask for. There is one more myth as a bonus. It is kind of a medical and non-medical, but medical myth, and this is mentioned by Gardner of Bees on Reddit. He said, or she said, "We don't say the Q word in dispatch. No, now, not never. And you know what? We don't say the Q word on shift as well." Saferstein replied to Gardner of Bees. He said, "It's a superstition. I can't tell you the amount of times I dropped the forbidden lingo and we kept cruising down at an easy 24. I never say a Q word, but is there a science behind it, Mr. Silver?"
So yeah, there actually is. So there is a study from 2019 by Brookfield et al. And what they did is they over 61 days, with 29 days being assigned to someone saying, "Today will be a quiet day," and that was the intervention group. And then, yeah, I did. And then 32 days with nobody saying the word quiet in any context, and that was the control group, with an average of 139 clinical episodes occurring on the control days, compared to 144.9 episode on the invention days. There was evidence of for non-inferiority between the groups. So no matter if you say it's going to be quiet or if you absolutely avoid it, it doesn't really change the amount of calls, surprisingly. So yeah,
who would have guessed?
Yeah, who would have known? But on a more sobering note, the paper did not take in consideration of stuff like staffing, burnout, wellness, which are continued issues all around the world in emergency services and hospitals. So it's still important to take care of each other and yourself when you're on a shift, especially if it's really hectic. Or there's lots of jobs.
Hectic like full moon, because we all know, right, that the full moon starts the absolute chaos. And I just will top up your myth with something that a user called Aspirin Dispenser said on Twitter. He said, "Yes, actually, full moon makes people crazy. There is a science behind it. A study of 13,000 motorcycle fatalities, around 5.3 increase in fatalities on nights where the moon was full. This makes sense," he says, "since a full moon increases nighttime visibility, which would encourage more nighttime riding. Sorry. Studies also shown that there is a correlation between the lunar cycle and sleep quality, which could theoretically lead to people being more irritable and confrontational." I'm always confrontational. Doesn't matter what phase of the moon is. But guys, last thing now. I promise you a special tool that will help you to protect yourselves from so-called garbage science or bullshit science. Barry Handyside, a research paramedic, will tell you now what can we do. Barry, what can we do to protect ourselves from bullshit science?
Yeah, thank you for your question, Alex. So if we're talking about critically appraising research and research papers, there's a few kind of basic questions that we can ask of that as we go through the process. The first one is ultimately, is the research question relevant to what you want to find out? If you want to find out about the use of morphine in cardiac chest pain, then they're the types of papers that you probably want to review. Next, we want to decide and think about what type of paper it is. So there's a kind of hierarchy of how good papers are and research are, and that comes from kind of at the bottom an opinion piece, going up to a case study, and then you go up through case controlled studies, cohort studies, observational studies, and kind of towards the top end, we've got randomized control trials and then systematic reviews. So systematic reviews kind of review all of the evidence on a topic and come to some form of agreement or consensus. If we're looking at the individual papers themselves, you want to think about the number of participants and the demographics of those participants. And again, are they relevant to what it is that we're trying to find out? Is it a specific gender or a specific age category that we're looking for? So again, you can narrow things down or you can keep it broad. But if you keep it broad, then you just have to ensure that you acknowledge the fact that it may not fit exactly what you're looking at. Next of all, we're thinking about the sampling strategy. So how were participants recruited, and also the location of research, because different countries, different areas are going to have different setups to their healthcare systems as well. What methods were used and were they suitable to answer the research question? You're only going to know this by delving into the world of methodology and method sections and reading around the subject. Then we need to think about, was the research impacted by any sort of bias? So that could be the researcher affiliations. It could be who funded the paper or the research. And it could be the researcher participant dynamic. Did they know each other? Did they not? And again, that can potentially come back to the sampling strategy that we spoke about earlier. Was the research ethical? So again, all papers should have a research ethics paragraph, which states have they been given ethical approval or how they've ensured ethics have been met. Were there any conflicts of interest? So again, that kind of comes back to who the researchers were, who paid for the research, or anything else that was there, and were they declared. The contemporary issue within research is self-identifying limitations of the research. So again, it's always better to acknowledge, to understand and to know that your research maybe wasn't perfect and these are the reasons why, rather than having other people point them out. Kind of how current the research is. That's not to dispel any sort of idea that previous research doesn't count and isn't relevant. It absolutely is. But again, the more current and up-to-date the research is that you're viewing, potentially the better quality it is and the more informed you. When we look at any research, all I would state is if you're looking to discover something, be well read around a subject. Don't take one or two papers and think that they have all the answers. They don't. If you want to learn and you want to improve and you want to be well informed, you have to read around a subject. And a way of doing that is those papers that you have got and you have picked up, look at their reference lists, go through their reference lists and read those papers. Not all of them, but the ones that kind of catch your eye. So I give you some kind of basic questions to go through. There is much more professional tools out there. And certainly one of them is the Critical Appraisal Skills Program. So CASP. If you Google that or search for that, they've got a number of tools available for a variety of different research papers. And it takes you through in a structured way, asking you questions to find out about each of those types of paper. And then you can kind of come to some sort of conclusion. So I think Alex is going to put a link up with that. Have a look, see what you think. But yeah, other than that, it's just go in with an open set of eyes, really, and ask questions of the research.
Ladies and gents, that was Group Call Live. Thank you so much for tuning in. And we see you guys in 2 weeks. Thank you and goodbye.